most, it's the best. Okay? This is, if you want to determine the size, chest x-ray is a screening, but it's not usually requested only for a different indication. Annual PE, chest x-ray, lumaki. Oh, dali, CT scan. Okay? Echo, oops, I see something. We do an EET, and then what they see is a widening, an aneurysm. Sometimes they will still again go to this one. Alright? If you have a high suspicion, go for CT and MRI. More expensive, but in the long run, it's the best modality to use. So, how do we manage? So, what causes aneurysm? Diba? Increase what? Pressure, shear force, destruction, degeneration, lumanan. So, how do we reduce the size from getting bigger? Reduce the pressure. Alright? So, how? One, by reducing the hypertension or reduction of the blood pressure. Two, slow down the heart. Kasi your heart, if it's beating normally at 90, and this is your vascular system, masisira, right? But if you lower down your heart rate, lower down the blood pressure, okay? So the tendency for the shear force associated with the increased cardiac output is actually reduced by taking this medication. Okay? Now, if things get worse, you could do replacement of your ascending aorta through the use of your bicuspid aorta and the use of your aortic valve replacement, because sometimes there could be aortic valve conditions. Repair is through the use of your prosthetic graft, and these are for patients with symptomatic ascending aneurysm. They replace it with your bicuspid aortic valves and are indicated only, again, the number is 6 or more than 5.5 centimeters or a growth rate of more than 0.5 centimeters a year. So last year it was 4.5, today is 5. Alright, that's already a good marker for much more increased surveillance. And if the next year is 5.5, it's already a good indicator that we need to have this repaired. Now, for those with degenerative descending thoracic aorta of more than 6 millimeters, you could have an endovascular repair. So what they do is they put a stent, all right, inside, and they replace that area that is that has that aneurysm. Okay, for those with 4.55 or those with an increased diameter of 1 centimeter a year. So this one is already your indication for treatment. Now, from thoracic, we go to abdominal. For abdominal aneurysm, again, males, elderly, history of smoking, and history of atherosclerotic diseases. So, this is mostly asymptomatic. Usually, 90% of the time, patients will get diagnosed, they already have an aneurysm more than 4 centimeters already. And found below at the level of renal artery, so mas mababa. The risk of rupture usually increases for 5. For abdominal, for thoracic it's 6. For abdominal, it's 5. Look at the difference. 1.2, almost the same, it's less than 5, but remember the first one, thoracic, it's only 7%. This one is 20 to 40%. Your risk of rupture for abdominal aortic aneurysms is about roughly half the moment you reach 5 centimeters. All right? So this is more aggressive in terms of the development of possible rupture. Again, a lot of them will be asymptomatic. It could be an incidental finding for other procedures. Nagpa-CT scan ka because of an abdominal problem. Suddenly, they saw that you have an abdominal aneurysm. For people who are thin enough on physical examination, palpable, pulsatile, okay, expansive, non-tender mass. Now, people, doctors, when you see a thin person with a palpable, pulsatile mass, don't touch it, okay? Baka pag kinatok, patay. Alright, killer number 1, okay? So don't touch it. If ever, please, just put a stethoscope, hear it if it's a brewing, then call your resident. Do not do anything that would kill your patient, alright? Okay, don't press. Diba lagi natin yan, may palpation, percussion, inspection. There is a scaphoid abdomen with clearly palpable, pulsatile lesion located at the peri-umbilical area. What is the next after inspection? Auscultation. I feel a brewy. Next? Would you still percuss? Not done. Palpation? Not done. Okay? Don't do it. Okay? Baka bigla na lang manigas yan. Ay, patay na. Kasalanan nyo pa. Alright? So, others are usually secondary to the expansion and compression on contiguous organs in the area like chest pain, back pain, or for more severe cases, scrotal pain. Layo, di ba? Pero kasi it's below the renal artery and then it can compress the nerves there. Obviously, abdominal pulsation. So, aneurysm pain or hypotension may indicate impending rupture and is a medical emergency because they need to go to the OR or ICU in order to correct it. So, when they complain of severe pain at abdominal area going to the back, associated with diaphoresis, hypotension, bring them immediately to the ER. Don't tell the patient, ay, ulcer lang yan. No, it's not an ulcer. Especially if you meet the three conditions. Male, smoker, elderly. Alright? Male, smoker, elderly, abdominal pain, diaphoresis, slightly hypotensive, ER. Don't do anything else. Okay? So diagnostic can get the abdominal X-ray. Sometimes we do immediately abdominal ultrasound. So this one is usually used in order to determine the growth rate of the aneurysm and look for the transverse and longitudinal diameter. So if it's growing, you can need to also to check on the mural thrombus. If there's a thrombus formation that may cause, all right, obstruction in your lower extremities later on. Okay. For screening, again, if you meet the criteria, man, smoker, age 65 to 74 years, or siblings of patient with aneurysms, or patient with history of thoracic or peripheral aneurysms, you need to have them monitored. But this one, immediately, you can have them done at least every few years, just in case they fit the criteria. Okay? So, for contrast CT and MRI, they will tell you the specific location and size of the aneurysm, plus the need, if you're going to plan for an endovascular or open surgery, you need an MRI or a CT scan because they will tell you the exact location, the size, and whatever else that they need to determine in order to have a successful surgery. Contrast aortography is used for evaluation. However, because of the contrast being used, there is an increased risk for bleeding, allergic reaction, or sometimes development of embolism. Okay, and it may underestimate the true size of the presence of a mural thrombus. Why? For unlike MRI, which shows both inside and outside, invasive aortography would only view the size of the lumen. Okay, not outside. Okay, so minsan na-underestimate nila the true size of the aneurysm. So treatment, again, male elderly smoking, malabang elevated na rin yung cholesterol. So give your statins even if you have normal cholesterol at that age, you have atherosclerosis already. So you reduce. Operative repair can be for people with symptomatic with rapidly expanding aneurysm. Is either you put an aortic stent graft or a prosthetic graft. Okay. For people with symptomatic, the golden number is more than 5.5 centimeters. However, there is a post-mortality rate of about 1 to 2%. Okay, but those with acute rupture, even if they do surgery, will have a mortality of around 45 to 50%. So that's how toxic it is. Okay. So even if you are able to bring them to the ER, immediately going up to the operating room, if it's a ruptured aortic aneurysm, the risk for mortality is around half. So you have to prime the patient. So though if you want to go to surgery, vascular surgeons, you really need to know, prime the patient, the relatives first. So, we now with that, no? So, acute aortic syndrome is similar to acute coronary syndrome. Alright, an acute condition associated with the effect of the aorta. This could be secondary to an aortic rupture, aortic dissection, an intramural hematoma, or a penetrating atherosclerotic ulcers. So these cause pain. Kirot, masakit. It can be secondary to a lot of things that I discussed in one table. It could be degenerative, your age, you have Ehlers-Danlos syndrome, your Marfan's, hypertension, inflammation, you have Takayasu. It could be even pregnancy can cause that, or trauma. Sinapak ka, malakas ang pagkakasapak sa'yo, it could also induce that, right? So aortic dissection, okay, can be circumferential or transverse tear of the intima. So inner lining chap, causing, because of the shear flow, opening it up bigger and bigger. Okay, usually it happens at the right lateral wall of the ascending aorta. It can usually seen among the descending thoracic aorta below the ligamentum arterioso. Usually again, 6th to 7th decade of life. So mostly the elderly because of the chronic degeneration, atherosclerosis, etc. Why is it that men are more prone to it than women? Because protective ang hormones ng babae to these conditions. It's protective. However, once you stop menstruating, you literally become men. So, nag-increase. But because men, because of their constitution, will have it more often than females. Okay? So, the dissection will tear. Okay? Papasok yan. Okay? So, there's an intimal tear, and dissection means binubuka. You're opening it up, increasing the size, causing blood to enter. Okay? So there's a primary intimal tear with dissection into the media. You can have medial hemorrhage, okay, or dissection or interruption of the intima, and dissection of the lamellar plates creating a false lumen. Nagmumukhang aneurysm, but it's mostly a dissection. So napunit, it enters, it increases in size. It usually goes down, but sometimes it goes up, no? But most of the time, the dissection goes down, okay? So there are two variants. You can have your intramural hematoma without a flap, or a penetrating atherosclerotic ulcers. So for intramural hematoma without an intimal flap, there is rupture of your vasa vasorum with hemorrhage into the wall, and it occurs in the descending and progress to rupture, pumuputok. For penetrating atherosclerotic ulcers, there's erosion of the plaque in the aortic media. So there is already a plaque, and it eroded, penetrates the intima, causing the dissection. It is usually localized, and it's usually seen in the middle and distal portion of the descending aorta. It is usually seen among patients with extensive atherosclerotic disease, and erosion can lead to false aneurysm and or rupture. Causes, again, almost the same. So very easy. Just remember the table. You would also always know the causes. Medial degeneration, secondary to either your age, comorbid conditions, genetic predisposition, infection, etc. Increased aortic wall stress, probably secondary to hypertension, tachycardia, etc. And the major causes of morbidity and mortality are your genetic conditions, your inflammatory conditions, third trimester pregnancy, all right? And weightlifting, cocaine use, and deceleration injury. So this one are not as common, but they do occur. Okay, so mga nagwe-weights dyan, okay? If you suddenly feel lower back pain, abdominal going to the back, stop everything, have yourself be checked, no? Wala naman cocaine dito, no? Jutsa lang po, meron paminsan-minsan, edibles, okay? But deceleration injury, those with on motorcycles, okay, or cars, okay, they could cause that traumatic injury. Now, we classify aneurysms based on two classes, DeBakey and Stanford. Now, DeBakey, actually focuses on the ascending aortic aneurysm. So that's the Becky type 1. The Becky type 2 is focused mostly on the ascending aorta. Type 3 focus on the descending aorta. So 1, 2, 3. 1 is the whole ascending and descending. 2 ascending only. 3 descending. Now Stanford type A is only mostly ascending. Type B is mostly descending. Alright? So it's much easier to use Stanford because it actually correlates more with the type of aneurysm that you have. Management does not differ if you classify them as DeBakey or Stanford. It will depend. Will not depend. You just need to it's usually for classification purposes only. Now, how do we know that this is a aortic dissection? Okay. Sudden onset of a searing, tearing pain with diaphoresis. Sakit, either going down, going to the back, going to the legs, with sweating. Alright? It's localized at the front, back, or interscapular area, depending on the area. And migrates with the propagation of the dissection. If the dissection keeps on going down, the pain keeps on worsening, pababa. It may also occur with syncope, dyspnea, and weakness. So yung mga compressive structures, no? Examination, patient could be hypertensive, hypotensive. There could already be loss of pulses if it's severe enough. You could hear aortic regurgitation. They could be manifested by bounding pulses, wide pulse pressure, a presence of a murmur, and signs of congestive heart failure. Pulmonary edema, spinal cord ischemia. You can have your paraplegia, weakness, bowel ischemia, hematuria, and myocardial ischemia, and compression of adjacent structures, and hemopericardium and cardiac tamponan. So depending on area, it will go back to the heart, going down, may have neurologic symptoms, may have abdominal symptoms. So in effect, unless you're very suspicious, you would think that it could be secondary to other conditions, di ba? Because they're not very specific. What is specific is the pain, the character of the pain, and the associated symptoms. Pwedeng nagkaroon siya ng paraplegia without pain, think of something else. But nagkaroon ng paraplegia with pain, think of an aneurysm. Alright? Pain plus these conditions. Okay? So, X-ray scans, you could see a widening superior mediastinal, presence of effusion, but effusion may mean a lot of things. No? So, you need to have a very high index of suspicion. Echo transthoracic can have a 60 to 85 sensitivity. You need, for transthoracic, it's very easy because you can order it anytime as compared to your esophageal. Presence of aortic regurgitation and pericardial effusion will increase the risk, the sensitivity for you to diagnose it as dissection. CT MRI has a 90%. CT you could do it in a few minutes. Dalhin mo sa CT scan, put siya ng contrast, makikita ka agad. And it can identify the intimal flap and extent of dissection so that surgical management or medical management can be instituted immediately. So treatment, put immediately the patient to the ICU. Never on the ward, never on the private room. Alright? IV parenteral beta blockers, okay, like your esmolol, the betalol, and your ARBs, okay? ACE inhibitors, ARBs, your CCBs. Anong specific na CCBs that can lower your heart rate and blood pressure? Pharma. And nifedipine, will it do it? Why? Side effect is tachycardia. Felodipine. Yes, no. How about diltiazem? Yes, no. Raise your hand. Who says yes? Hello? Pati ilan lang? Who says no? Raise your hand. Diltiazem is one of the treatments. What about verapamil? Yes, all right. Only those two calcium channel inhibitors that are known to have a chronotropic effect. They decrease the heart rate. Okay, so type B, regular monitoring. If you have the big stand for type B, you just need to monitor if the patient gets better. 10-year survival is usually more than 60% and the mortality is only 10%. So bantayan mo lang, maximize. Now, if it's really surgical, it's the preferred treatment if you have a stand for type A, assembly. No? So graft placement, valve replacement, or repair. Again, even if you do it, your mortality is around 15 to 25%. Why? Because of the proximity to the heart, you can have directly an MI, paraplegia, renal failure, sepsis, tamponade, and or hemorrhage. So, okay, you need a thoracic endovascular repair or a combination of both. So you put a stent and you operate it. Okay? So more aggressive for type A. For type B, sometimes you just need to observe the patient. Occlusion, on the other hand, okay, is secondary to a narrowing of the aorta, secondary to chronic atherosclerosis. Okay? There is distal abdominal aorta below the renal arteries, and it usually affects your iliac arteries. So what is the symptoms? It's usually claudication. What is claudication? Pain on? Night pain? Sitting pain? Walking pain. Alright? So you're technically asymptomatic if you're not doing anything. Then you walk 25, 50, 100 meters, then you start to feel pain. Pain is usually described as ngalay or tightness. Okay? Or, ano ba sa English yung pulikat? Cramps. Yan, that's the correct term. You develop cramps when you walk farther away. And when you rest, it stops and goes. Okay? So, not only do you develop calf claudication, but they could also develop pain on their buttocks, your thighs, and sometimes it cause impotence. Okay? Your Rich syndrome. Physical findings, if it's severe enough, there could be an absence of your femoral and your distal pulses. Okay? So usually I use to check pag may symptoms of claudication, I check on the popliteal and the dorsalis. Okay? So if it's more severe, I go up to the femoral pulses. Okay? So you can have also abdominal groovy and common femoral arteries. You can have atrophic skin, numinipis ang balat, hair loss. Dati balbon ka sa taas, wala kang balbon sa baba. Alright? Cool extremities. This is warm, this is cold. Pallor on elevation. When you raise it up, becomes pale. And rubor on dependent position. So depending on the position, it changes color. For laboratory exams, you can have your duplex velocity pulse volume recording, or what your duplex ultrasound, or what's sometimes called Doppler ultrasound. MRI, CT, or aortography in order to determine location, the size, and what are other possible causes. Management, you can have an operative treatment. Most of the time, if it's severe enough, it's an operative treatment. You have to open it up because there's already signs of ischemia for the lower extremities. Okay? So you can have other conditions, could be lifestyle limiting. If you like to jog, you would be advised not to do it anymore. It can also cause debilitation and critical limb ischemia. Okay? For people who develop acute aortic occlusion, sudden obstruction, it's a medical emergency and may result from a saddle embolus or an in situ thrombosis. So, saddle embolus suddenly from one place, it went downwards, and it causes an area of bifurcation most of the time. It occludes that area, or an in situ thrombosis when it shuts down on that area. It can be a severe breast pain, coolness and pallor of the lower extremities, and abscess of distal pulses bilaterally. Okay? Diagnosis again, your MRI, CT, and aortography. So, just to make things clear, pag vascular on my exam, there's no such thing as chest X-ray, ultrasound. I usually prefer an answer of CT, MRI. Alright? Understand each other? So management is emergency thrombectomy or revascularization. So you could do thrombolysis, but what you usually do is a non-invasive, they do thrombectomy by passing through the femoral artery and opening it up, okay? And revascularization with thrombolytics. Now, for aortitis, from the word itself, itis, it's an inflammation. No. Inflammation of the vasculitis can be secondary to Takayasu and giant cell arteritis. Doc, why specific Takayasu and giant cell? Vasculitis is large, medium, small vessel. So per vessel, may corresponding conditions and nag-interact. But for large vessels, only Takayasu and giant cell. So for rheumatic conditions, on the other hand, autoimmune can have your RA, your spondyloarthropathies, Behçet's, Cogan syndrome, IgG4-related systemic diseases, and what we sometimes call, it does not fit anything, idiopathic aortitis. Okay? So rheumatoid arthritis is inflammation of your manifestations, polyarticular joint pains. HLA-B27 is usually in the back, in the abdomen, and in the eyes, and in the skin, psoriasis. Behçet's syndrome is usually ulcers. Cogan syndrome is usually the eyes and the ears. Okay? IgG4-related systemic diseases is usually a tumor-like condition. And idiopathic aortitis is because I cannot fit it in here. Alright? So it has no criteria fulfilled. That's why it's idiopathic. Okay? So we go first with Takayasu. Takayasu is what we call a pulseless disease that may affect any parts of the aorta. And actually, not only the aorta, aortic arc, and the thoracic abdominal, but other parts of the vascular system. And it may occlude various arteries with development of aneurysm. So if you see that, no, lumiliit, the lumen decreases in size. Similarly, this one is totally occluded. So do they sometimes have manifestations of a stroke-like syndrome? However, this one usually, because of the occlusion, increase ang flow, and that's why you could hear your bruise. No, they usually develop alternate passage. How do they call that? Collaterals. Yes, they usually develop collaterals. That's why, in spite of the fact it's being included, it can still function. All right. Pathology is a panarteritis. It does not only occur here where the occlusion occurs, but actually occurs on the hood. Autoimmune conditions are holistic, no? They attack everything, but a few organs are just being manifested. There is infiltration by your mononuclear cells, your giant cells, with destruction of your vasculature. It's seen in women. Okay? Now, itong mga itis, it's mostly women. Because again, not unlike men, women are by epigenetics prone to develop autoimmune conditions. Kaya karamihan ng mga patients kung may autoimmune disease are females. Alright? So most ng young women of Asian descent. They have manifestations of constitutional symptoms like fever, fatigue, joint pains, and elevated ESR. Okay? Upper extremity, they could cause claudication, ischemia, and syncope. But on physical findings, you could usually see the presence of bruise, abnormal pulses, or a lack of pulse. 0/0, 140/100. Okay? That in itself, with a bruise here, bruise there, could already give you a probability that this is Takayasu. Management, when taken early, is usually use of glucocorticoids and immunosuppressants. Lowering the inflammatory condition actually helps improve the symptoms of the patient and sometimes make them go into remission. However, for more severe, with those with claudications, surgical bypass and stenting is usually recommended. Okay? So it's a chronic progressive condition if not treated adequately. Giant cell arteritis is more common in women. Signs and symptoms are usually headache, elevated ESR, and very visible temporal arteries. Okay? So it's a granulomatous lesions on the entire arterial wall, and usually you could diagnose it by age, ESR levels that are elevated and by biopsy. Okay? So there's obstruction of medium-sized arteries and major branches of the aorta. Treatment is usually again the same, glucocorticoid and methotrexate, and they do respond well with the treatment. So other autoimmune conditions, the aortitis involves the ascending aorta, sinuses of Valsalva, microvalvulets, and adjacent myocardium. It can involve the whole vasculature actually. So manifestations, they may present with aneurysm, aortic irritations, abnormality in the cardiac conducting system. The question is, are they common? They're not as common. Okay? Still, for people with this kind of conditions, they still have mostly the organs that they're usually involved in, like RA, the joints, no? But if you present with a patient with the RA with some other symptoms, try to check them out because they may have involved other areas. Okay? So pag autoimmune, it affects all, but its major effect is on the condition label. RA, joints. Psoriatic arthritis, skin and joints. Okay? Reactive arthritis, infection. Relapsing polychondritis is the attack on your cartilage. So just to give you an idea, relapsing polychondritis is usually seen among females and the very young. What happens? Nasisira ang cartilage, bumabag, they develop floppy ears. Alright? And, ayan, saddle nose deformity, nawala yung bridge mo, dati sobrang tangos, bigla ka na pango. Ha? Ganun yun. The problem is, it is usually also seen among patients with Wegener's granulomatosis. Ang problem though with Wegener's, it involves the upper respiratory tract and the lungs, and has a higher morbidity. I have a 16-year-old with relapsing polychondritis, was seen in JBL. She was okay with the glucocorticoids, then had a flare. Nag-collapse yung trachea. So they have to put in a tracheostomy tube and have to undergo cyclophosphamide pulse therapy in order to get better. So it can affect everything else. Again, idiopathic does not fulfill the criteria. It can present with vague constitutional symptoms, fever, abdominal pain, and is characterized by adventitial or periaortic inflammation with thickening of the aortic wall. And it may be associated with other aneurysms and fibrosis. Again, treatment is almost the same as the previous. Infection, okay, you can have your mycotic aneurysm because of the direct invasion of the aortic wall, usually at sites of atherosclerotic plaques causing the aortitis. It can be any bacteria, usually your gram-positive bacteria. Okay? So bacterial proteases causes breakdown your collagen, weakening the aortic wall, causing formation of a saccular aneurysm, usually caused by your staph, strep, salmonella, or it usually affects again the elderly, again males, fever, manifestations of an infection like fever and sepsis. You have chest, back, and abdominal pain, sometimes with a history of diarrhea. Okay? Diagnostics, cultures are positive, again your CT MRI. Treatment is through antibiotics and removal of the graft, surgical removal and graft placements. Okay? Because this is already infected. Even if you treat it, they will always be remaining. So you have to remove the affected area and place it with grafts. Syphilitic aortitis, very specific siya because it affects the proximal ascending aorta and aortic root. Okay? It results in dilatation and aneurysm, which may be saccular or fusiform and usually asymptomatic. But manifestations or clues to that syphilis is the compression symptoms or if rupture develops. Okay? So, if you see the previews of invasion, granulomatous, this is obliterative endarteritis of the vasovasorum due to the invasion of your spirochetes leading to inflammation, destruction, calcification, and scar formation. X-rays have linear calcification of the aorta. Okay? So, usually syphilis waxes and wanes. Sometimes you had it, you don't know you had it, and then you just lived your life. Okay? So, it's present as an incidental finding decades from the initial impression. Okay? So symptoms can have narrowing of the aortic ostia, compression of the subsacral rupture. So aortic regurgitation. So symptoms manifest first. So history, hindi mo maalala. So diagnostics, you have your RPR, for fluorescent treponemal antibody test. Treatment is penicillin and it's very severe surgical excision. So for if you want to go into IDS, infectious disease specialist, history is very important to them. So you have to really delve on a lot of medical history for these patients. Kasi who remembers their syphilis history before, di ba? So we now go to your arterial disease of the extremities. A few more slides. Yeah, matatapos na. So, peripheral artery disease is something that's very common. A lot of your probably relatives will probably have this in one way or another. So it's a clinical disorder caused by stenosis or occlusion in the aorta or arteries, and it's secondary to mostly atherosclerosis for people 40 years old and above. But most again, probably in the 5th and 6th decades. Again, male, smoker, hypertensive, those with diabetes, hypercholesterolemia, and renal insufficiency. Pathology can have atherosclerotic plaques with deposition, thinning of the media, patchy destruction, fragmentation, and thrombi formation. So all degenerative conditions that may be associated with being elderly, hypertensive, and smoker. Okay. Signs, you can have it in the abdominal aorta and iliac arteries. This is the most common for symptomatic patients. Symptomatic. Those that are symptomatic, they can have it at the femoral and popliteal area or tibial and peroneal areas. Manifestations, your claudication, and usually occurs during exercise and relieved by rest. For more severe ones, even at rest, you still feeling the pain, cold, numbness of the foot and toes, usually at night. Right? Physical examination, you can have absent pulses, you can have bruise, atrophy, lumiliit ang lower extremities, hair loss, thickened nails, smooth, shiny skin. Parang madanda tong smooth, shiny skin. Alright? But you don't need to shave anymore. Alright? But these are signs of increased ischemia. That's why there's hair loss. The shiny skin is secondary to dryness of the skin because of lack of oxygen. There's reduced temperature, it's pallor, and cyanosis. You could develop gangrene in the long term, or ulcers, and you can have dependent rupor. So pag tumatayo siya, tumumula yung paa niya. Diagnostic, you can do in your ankle brachial index, wherein observation is that the ratio should be 1 to 1.4, which is normal. Less than 0.9 is abnormal in diagnostic of peripheral artery disease. You could also do, this one needs a special equipment, so that's why it's usually not done. What we usually do is a duplex ultrasound, lower extremities. Stress testing to determine how far you could go before you have claudication. Segmental pressure monitoring, etc. MRI, CT, and angiography only for potential surgical patients. So this is the only time that CT and MRI will take a backseat. This is usually medical management. Treatment is risk factor modification. If you're hypertensive, control the blood pressure, control the cholesterol, give blood thinners, etc. Antiplatelet treatment like aspirin, clopidogrel, Vorapaxar. For more severe conditions, you can give your oral anticoagulants like your rivaroxaban. Supported treatment like regular exercise up to the level that you can still walk, but you gradually increase the length of the walking. You could also give your cilostazol and pentoxifylline or bone marrow-derived vascular progenitor cells, which tend to improve the induced angiogenesis. But this is mostly still not being done. Revascularization is when you develop critical limb ischemia. So what is that? There is disabling progressive or severe symptoms of claudication. You're always in pain. You cannot feel your legs anymore. All right? It's usually there's already numbness, rubor, etc. So it could be done as percutaneous transluminal balloon angioplasty, stent placement, or more invasive one, an arterial bypass. This will be dependent on what area in the vasculature the occlusion occurs, okay? Fibromuscular dysplasia, on the other hand, or hyperplastic disorders affecting medium-sized arteries, is mostly seen among females. It may affect your renal, carotid, iliac, and subclavian arteries. So there is intimal fibroplasia, medial dysplasia. So what you have are like rosary beads, no? Nagkakaroon ng, because this is fibro, this is dysplasia, this is the fibrosis, this is this plastic area. So there are alternating areas of thin media and fibromuscular ridges and what we call a string of beads. Its manifestations are similar to your PAD. Berger's disease, okay? So your thromboangiitis obliterans is an inflammatory occlusive vascular disease, usually among the small and medium-sized arteries and veins. Usually what affects is the upper extremities and affects men less than 40 who are smokers. So if you do ever smoke, kindly already think that this is one of the conditions why we do not really promote smoking. Now the next question is among you guys is, Doc, how about vape? Diba? Vape is very common nowadays. They have already replaced smoking as the. Now, do we have incidents among people who are vaping? So far, none. However, we see people who develop an autoimmune reaction to vaping. So the chemicals causes an immune reaction in the lungs. So they do develop interstitial lung disease. But the evidence, unfortunately, is still low. So yung correlation, so pwede pa kayo mag-vape, wala pang ebidensya. Or you could always say in terms of evidence-based medicine, the evidence is low. Alright? There is a correlation, but the evidence is still low. So, the pathology is infiltration by your polymorphonuclear neutrophils and development of thrombus, obstruction your vascular ligament, and it is progressive. It is continuous progressive. Okay? So you develop perivascular fibrosis, thrombus, and recanalization, then thrombus again, you recanalize, etc. So clinical features, you have claudications, even for the hands, nangangalay, pinupulikat. You have Raynaud's phenomenon, and you have migratory superficial vein thrombophlebitis. So there is swelling. Then worsening could have absent distal pulses already. Diagnostic, MRI, CTA, conventional arteriography, histology, and smooth tapering segmental lesions and collateral vessels on aortography. So management is usually supportive. Stop smoking. Okay? For worse patients like the one you saw before, it's amputation. There's no use already because it's already gangrenous. Okay? Acute limb ischemia, on the other hand, is sudden cessation of blood flow to an extremity. You have no predisposing factors before, and then suddenly, bam. Okay? So, severity can depends on the location, extent of occlusion, and development of collateral vessels. Causes can be due to embolism, thrombus in situ, arterial dissection, and trauma. So, sudden. Okay? Embolism, you cannot really predict. Trauma is suddenly you have an accident and dissection. So look at this one. Manifestation, there's severe pain, paresthesia, numbness, and coldness of the upper extremity involved. And because of the nerve can be also involved paralysis. There is loss of pulses, cyanosis, and decreased skin temperature. They're usually stiffening, weakness, and absent PPRs. So kung iniisip nyo, alin ang may problema? Yung puti. Hindi yung pula. Ito, may problema. Treatment, you could have IV heparin, thrombolysis or thrombectomy, remove the thrombus, surgical thrombolectomy, arterial bypass, intra-arterial thrombolytic therapy, RTPA, replace, tenecteplase. So, treatment for stroke, treatment for acute MI, that is ST segment elevation, they are also useful for this one, okay? And if the condition is less than 2 weeks, okay? Percutaneous mechanical thrombectomy, amputation, or long-term anticoagulation. Atheroembolism, on the other hand, are multiple small deposits of fibrins, mini occlusions. Okay? Platelet and cholesterol debris embolize from the atherosclerotic lesions or aneurysmal sites. It occludes the small vessels. Yan. I usually see that on a patient with scleroderma. Okay? And complaints of acute pain and tenderness, ischemia, or what you call a blue toe syndrome, and may lead to digital necrosis and gangrene. So multiple lang, usually 1 or 2 digits lang, usually lower extremities or sometimes of the hands. For people with autoimmune disease, it's common for lupus, APAS, and scleroderma. Management is usually supported treatment. You give your diltiazem, you give your clopidogrel, you give your aspirin to treat for the pain, or if more severe amputations or analgesics. Thoracic outlet compression syndrome is a compression of your neurovascular bundle, your nerve, artery, and vein, okay? And courses to the neck bundle. They may complain of shoulder and arm pain, weakness, and paresthesia. Usually they complain of here, going down. They have difficulty raising it or it's weak, okay? They could have claudications, Raynaud's, and ischemic changes in gangrene, and subclavian and axillary thrombosis. So there are a lot of things that may obstruct that. It could be an extra rib, it could be a compression by your muscles, it could be a position, okay? So conservative management, usually physical therapy like rehab, it will improve that. Or surgical management like removal of the rib, freeing of the ligament that's compressing the neurovascular bundle. So Raynaud's phenomenon, okay, that's for your So this is episodic digital ischemia that is triggered by cold. Okay? So there is digital blanching, cyanosis, and rubor. They may occur at the same time. So puti ito, violet ito, pula to. Alright? They may occur at the same time. And results from vasospasm, cyanosis, and reactive hyperemia. So the trigger is cold. And they would go through the phases. Sometimes they just go one phase. Most scleroderma patients only have this. Namumula lang. Namumutla lang. Other than that, they don't go to the other phases. So primary or idiopathic Raynaud's phenomenon is this Raynaud's phenomenon that cannot be explained by other diseases. Most of the secondary Raynaud's phenomenon are usually by connective tissue diseases. Lupus, scleroderma, etc. They may also be a manifestations of other conditions like your thoracic outlet obstruction, pulmonary hypertension, tumors, dyscrasia, trauma, and toxins. That's why Raynaud's syndrome, if present, is already a requirement for you to extensively check your patients for other signs and problems. Treatment is usually supportive. We usually give nifedipine or diltiazem. We could give also prazosin, doxazine, perazine. For more severe conditions, we usually give our Viagra, Cialis, okay? So your PDE inhibitors, okay? Or for more severe, like for people with thoracic outlet obstruction, digital sympathectomy in order to reduce the pain, okay? So people with Raynaud's sometimes get better with sildenafil, okay? Acrocyannosis are arterial vasoconstriction and secondary dilatation with resulting persistent cyanosis. Hands are more common than the feet, again, cold. So instead of pallor, they usually have cyanosis. Again, women are more than men, younger, and condition is persistent, and PE is usually negative. Secondary is usually secondary to multiple factors, okay? Most of the time it's secondary to a connective tissue disease, but other times it's infection. Fistulas, on the other hand, is something that's commonly seen because we usually do it for people undergoing hemodialysis, okay? So you can have, in itself, it's a connection between an artery and the vein. So for congenital, it's a persistent embryonic vessel that failed to differentiate. For acquired, it's secondary to create an access or due to trauma. PE, it's visible, it's palpable, it's you can auscultate it. So there's bruit, there's trill, there's bruit. You have edema, you can have varicose veins, and you can have pigmentations. Large fistulas may cause increased what the fuck? CO. I forgot. Anyway, cardiomegaly and heart failure. Cardiac output, sorry. Yeah. Because if it's a fistula, it's usually evident. Now, if you're not sure, you can do a duplex ultrasound, CT, and angiography to determine the size. Management, if it's localized, you can do surgery like embolization or radiotherapy. Congenital ones are usually treated conservatively. There's no need for surgical management. Now, we go now from artery to the veins, okay? For venous anatomy, they are both superficial and deep. They're connected to deep veins by perforating vessels, as you can see there. And deep veins accompany major arteries. Okay, so bicuspid valve directs the flow of the blood centrally. So when it passes through the veins, there's a gate that prevents it from going back down. So chronic venous disease are range from telangiectasia, reticular veins, to varicose veins. What are telangiectasia? If you know, if you're white enough, there's small spidery-like vessels, usually for those with very thin skin or those that are elderly. Reticular are like lace type, and varicose. You can have chronic venous insufficiency with edema, skin changes, and ulceration for those with chronic ones. Prevalence of varicose veins, only 15% for men, 30% for women. Okay? And chronic venous insufficiency are more common for men, usually seen among more than 70 years, and 20% will develop ulcers. So yung nakikita nyo nangingitim yung paa, nagsusugat, usually venous insufficiency yan. Varicose veins are dilated, bulging tortuous superficial veins of at least 3 centimeters in diameter, and could be also intradermal veins. Those are the blue-green veins of 1 to 3 millimeters. Yung mga nakikita natin dito. Alright? Telangiectasia or spider veins are very small, less than 1 millimeter, and near the skin surface with different colors and contour. So, primary varicose veins are defective structure that functions as a venous. There is a problem with the vessel wall, high pressure because they are not functional anymore, and cause include aging, pregnancy, hormonal therapy, obesity, and prolonged standing. The more pregnancy you have, the higher your risk for developing varicose. All right. Secondary could be due to increase your venous hypertension, insufficiency, or incompetence of the valves. Okay, and the development of your fistula. So, primary could be an intrinsic structure, functional abnormality. Secondary, it could be obstruction or poor valve problem, and thus cause thrombosis. Why thrombosis? Because it's supposed to be a continuous flow. You stop it, blood tends to coagulate on its own because of poor flow. Cause thrombosis. So manifestations mostly asymptomatic. A lot of people complain of their varicose veins, but they don't feel anything. Okay, it's just cosmetically not nice. So there's sometimes a complaint of adult ache, throbbing, tenderness, heaviness, or pressure in the legs, usually on standing, or more symptoms of similar to PAD, like cramping, burning, pruritus, swelling, or chronically ulceration. So PE, you examine the supine and standing, noted cutaneous manifestation and extent, look for edema, look for atrophy blanche. What's that? Atrophy blanche are the whitish dyspigmentation or cured ulcers. So nagkapeklat ka, di ba? This is the different color. Atrophy blanche just means a white scar. Okay? Venous ulcers that may be shallow with irregular borders or more severe ones. And exudates. Diagnostic, you have a request for your venous duplex ultrasound and look for absence of flow or the presence of thrombi or veins to collapse when compressed. They press on it. Okay? They need to recover. Reflux, okay, detected, and my favorite MRI and CT scan are rarely required. Brody's Trendelenburg test distinguishes deep from superficial insufficiency. What is that? They put a tourniquet here, okay, with it lying down. they see if the varicose veins forms, and if they remove it, it disappears. So, a positive and negative test. Pag deep siya, pag tinanggal mo, nawawala yung varicose. Pag superficial siya, whether you put it or remove it, it's still there. Perthes test is similar to Brody's, but you ask the patient to walk. Okay? So, assess deep vein obstruction. Supportive measures, you could have regular leg elevation, compressive stockings of about 20 to 30 millimeters mercury. If you already have edema, 30 to 40 millimeters mercury. That's very painful. So a lot of people do not like compressive stockings because of the tightness they feel. Exercise training and absorbent dressing in order to cure the ulcers. Medical treatments are usually no specific therapy. You treat the symptoms. Okay, if you have edema, you have diuretics. Sometimes you give steroids, diazepam, aspirin, etc. Surgical, you ablate, we sclerose, we stab. Okay, so anything to remove the varicose vein. Sometimes we remove. Okay, vein stripping. Okay, this is ligation, stripping of the small saphenous vein. Could be surgical bypass and reconstruction already for people with the ulcers, and valvuloplasty or vein transfer. Lymphedema, okay, is impaired transport of lymph. It's swelling of one more limbs, so occasionally involve the trunk and genitalia, and there is usually caused by Starling forces. Okay, so increase in pressure, lumalabas yung supposedly papasok because of the oncotic pressure, because of the abnormal Starling forces, lumalabas. There's persistent leads to mononuclear infiltration, fibroblast and adipocyte, leading to collagen, adipose in the skin and soft tissue. So lumalaki. This is not edema. Edema with diuretics goes down. Lymphedema, even with diuretic, does not go down. So you can have a lot of conditions that may be associated with it. Okay? One thing that gives you a clue of whether it's a pedal edema versus a lymphedema is that when you elevate it, pedal edema goes down. Most of the common questions that we usually ask is, when you wake up in the morning, does your leg look normal? If the answer is yes, that's a pedal edema, fluid. If the patient says, Doc, it's the same. Even if I sit, lie down, wake up, the leg looks the same, it's a pedal edema. Alright, remember that. And you just need to determine what causes it. So para, you already know what parasitic causes lymphedema? Huh? Alright. So aside from that, you could also be secondary to infections, other abnormalities, and even malignancies. These are nice to know. Okay. So manifestation, it's a painless condition with swelling. Okay. Initially beating, but once out the post collection, there's this one. Okay. And there's thickening of the skin. You can have pudiorange, and chronic edema causes the leg to be indurated, and fibrotic appearance, woody, and non-beating. I would not bother you with this. This is just a staging. All right. So diagnostic can do an abdominal and pelvic ultrasound to determine the cause of what causes the pedal edema, a CT and MRI, and lymphoscintigraphy or lymph angiography. What's that for? To determine if it can be curable with surgery. Right? So supportive care, physical therapy, massage, the use of a lot of compresses, limb reduction procedures, liposuction, and limb angiogenesis. And that's my last slides. Thank you very much. Bago tayong ulit. Alright? Thank you. Any questions, by the way? Sure kayo? Alright. Thank you.